Yeah, welcome to Children and Seniors this afternoon. I've got a special guest up here that I'd like you all to meet. This is my grandson, Brooks. Say hi. Want to say hi? He's not going to say hi. Yeah. See, we're on TV. He's just going to blink at it. And my daughter, Jessica, and her husband, Nathan. So they are here because I am missing Brooks terribly, and I haven't seen him since Christmas. And so I'll let you go see Mommy. All right. Okay, so we just have the one item. Is he waving? Yeah, he said, "Hi, everyone." You did? Okay, we just have the one item of business that we wanted to hear from Tanya Dorf-Bruner about oral health and the impact that oral health has on our children and our senior citizens. So, welcome to committee. We haven't seen you in here this year.
Hello, there we go. No, I haven't been here yet this year, and I'm sad about that, but I'm really happy to be with you today, so thank you. Yeah, thank you. So yes, again, my name is Tanya Dorf-Bruner. I'm the Executive Director of Oral Health Kansas. I do have a PowerPoint, yes, and thank you so much. I think we even have the clicker, thank you. Executive Director of Oral Health Kansas, and I'll start out here just with a little bit, to make sure it's working, a little bit of information just about Oral Health Kansas itself, and I've kind of got a lot of content. I'll go through this as fast as I can, and if you decide it's too much, just say time out. There's a lot of data, so please stop me if it's too much. Let's see, oops. There we go. So Oral Health Kansas, we are the state's consumer oral health advocacy organization. We were founded about 19 years ago. We've got over 1,600 supporters that we count, where our focus is on advocacy, education, and public awareness. And there's a point here about making sure that, we've got a really broad and diverse board, not just oral health people, but from all sorts of walks of life that really represent that mission. I want to start with just what to expect today, and this is kind of the agenda of what I was hoping to cover. First of all, just an overview of some of the value of oral health to overall health, and then talking about kids specifically, what are some of the facts in Kansas, what are some of the coverage issues, and then solutions, and then repeating that for seniors. And then the other part of the agenda is, this is a photo I took the last time the legislature got shut down a couple weeks ago, so I think that might be on the agenda as well. That's a beautiful picture. So first, just getting into the value of oral health here. In case you don't know, tooth decay is 100% preventable. Most people end up somehow experiencing at some point in life, but it really is preventable, and that's a huge part of what we as an organization are working on, is making sure that as many people as possible can stay safe and healthy. Cavities actually are the #1 chronic disease in childhood. It's more prevalent than asthma. In fact, about a quarter of kids already have tooth decay by the time they reach kindergarten, and that's a problem, and so that's one thing we try to work on. Both cavities and gum disease, and those are the two dental diseases, both of those are infectious, and they both are transmissible. I'm going to talk about a really specific case about that here in a couple of minutes. Poor oral health does impact nutrition. If you don't have good teeth, you can't eat good healthy fruits and vegetables, those sorts of things. It certainly impacts overall health. Another bullet down there, for example, is chronic diseases like heart disease, like diabetes, are directly linked with oral health problems, with dental disease. There's even a real close link between pregnancy and the baby's oral health. If a pregnant mom has some tooth decay, the baby could end up being low birth weight. There's some problems that could happen. So it definitely impacts overall health. School performance, kids who have dental problems, who have tooth pain, they can't concentrate, they can't learn, or they can't eat, and they really struggle. And of course, economic success. When people have a nice smile, they can get a good job, they can be successful, and just like kids, if you've got pain, you can't concentrate at work. So it certainly is related to economic success. Just a little bit more than making sure. Oops. Maybe. I should have just left this with you after all. There we go. A little bit more about the kind of the background of oral health. It really, just the oral health itself can be out of reach for many people. I think a lot of us are just socialized to think of dental care as cosmetic. But certainly the commercials we see on TV are all about whitening and pretty smiles and the like. But we're really here today because for many Kansans, it's definitely out of reach. People who live in poverty, people of color, people with disabilities, and people living in rural areas more and more struggle to have access to adequate oral health. And I'll talk quite a bit this afternoon, about dental insurance coverage as well. It's also not accessible to everyone. As we all kind of know, it's considered kind of an extra add-on for both public and private health plans. That, of course, increases costs and decreases access. So I want to talk about, this is the the transmissible story I wanted to tell you. Diamante driver, I don't know if anybody's familiar with his story. His story is kind of the galvanizing one in the oral health community in this state and around the country. In 2007, a little boy named Diamante driver was 12 years old. He had a toothache, he had a dental infection. His mom tried everything she could to try to get him access to a dentist. He needed a $100 extraction. Wouldn't have been too big of a deal. It would have been painful, but no big deal. But the infection was transmissible and it went to his brain and it killed him. It's just horrific. And I'm sorry to say that this is the kind of thing happens all the time. We don't hear about it very often. It doesn't make the news. Since he lived in Prince George's County, Maryland, it's right next to Washington, D.C. Since he lived right there, it got a lot of media attention. And this is just a handful of the articles that showed up on TV, radio, newspapers. There's even a story on there from the BBC about this. Because there was so much attention focused on Diamante and his tragedy, the oral health community really came together and said, look, we can't have this. We've got to make sure that kids have access to care. We've got to make sure kids and families know how to be able to take care of themselves. We've got to fix this. So he really changed things in the oral health community for the better. But we think about him a lot. So on that note, hopefully we'll get a little happier. I'll go into the part about kids. We'll talk about facts first, and then coverage, and then solutions. So here is a little bit of starting with the facts. We issued a report card this year. We issued one last year, and we issued a new one this year called the Kansas Oral Health Report Card. Actually, and I think I forgot to bring it up with me. No, I didn't. I think you should have a copy. It kind of looks like this. You should have a copy in the materials you've been given. The report card compares Kansas data to national statistics so we can see where we compare. Are we above, below? We got a C, so that means we're really kind of where the rest of the country is. It doesn't mean, I always say my parents wouldn't have been happy with a C. I'm not happy with a C. But here's a few of the data points that are important to take a look at for kids enrolled in Medicaid. The first three are really about having access to a preventive dental visit. You can see the numbers are not good. Only 12% or 17% of kids 1 to 2 had a dental visit. And I'll talk a little bit more about that, about age 1 dental visits and the importance of that, but that's what should be the industry standard. It's not quite there yet, but if you can catch kids early, the first tooth comes out, they need to be in a dentist's office. Part of it socializes them to be not afraid of going to the dentist. If they're kind of in there from infancy, they get it. The one grade that's an A is 20% of kids 6 to 14 received a dental sealant on one of their molars. It's an A because we did well compared to the national numbers, but 20% is not good by any stretch of the imagination. So take all of these with a grain of salt, obviously. The children in the general population, the numbers are a bit better. And I think we'll talk about insurance coverage. I think that's definitely part of that issue. But again, back to sealants, 36% of third graders in the general population have sealants. So again, not a great number. I'm happy to be able to share this next set of data. So the Kansas Department of Health and Environment has a Bureau of Oral Health, and one of the things they do is run a school screening program, and they run a school sealant program. So they actually take dental hygienists and dentists out to schools. They screen kids. They put on dental sealants when they can. So this is the final report from their screening that they did in 2021 school year. So it's a final number. So I highlighted a couple of things just for you to take a look at. Look at those numbers. About 17% of kids did have untreated decay at that moment, and at about 2.7, I think it is percent, had urgent needs that were not being met. So that's for the 2020-2021 school year. Also note that's the beginning of the pandemic, so that's when dental care was really arguably hard to access for anybody, regardless of your status. And then flip forward to the current year. These aren't final numbers because we're still in the middle of the current school year, but the numbers are already better looking at those same two measures. Now we're down to about 15% of kids have untreated decay. It's still 15%. There's still a lot that needs to be done. And a little less than 2% have urgent needs. So that number has ticked down a little bit. So I think that's important to know that this data exists and that they're doing a great job over there at the Bureau of Oral Health. The next bit of facts is from, I'll back up, in the year 2000, the Surgeon General issued the very first report on oral health in America. It was really the beginning of an oral health movement in the country, and then when Diamante Driver passed, that was really the next period of oomph in terms of recognizing the importance of doing this work. In 2021, the Surgeon General's office issued a new report. It didn't come from his office. That's neither here nor there, but the federal government issued an updated report 20 years later. Where are we? And so that's where some of these facts come from. First one, just noting that over that 20-year period, we've certainly made some progress in reducing tooth decay, but not all kids are benefiting equally. Noting that integrating dental care and medical care is really helping, and that's a growing phenomenon, which is great. It notes that 20% of kids, and we know 1 in 5 people has a disability of some sort. Dental providers often are really nervous about serving people with disabilities. They don't know how. It seems kind of scary. So there's a lot of education that needs to be done with dental providers. We're doing a lot of that. Dental schools are investing in that now, but that's certainly an area of improvement. And then adolescence, I like that it was called out because it's certainly a little bit different. The first thing there is just that adolescence is when people establish habits, and a lot of adolescents will honestly grow into adulthood without dental insurance. So having good habits and knowing how to take care of themselves at that age is important. Again, there's about half of adolescents will have experienced tooth decay. And then that last one's important too. Students starting using tobacco and substance abuse sort of things in adolescence, and those certainly affect oral health as well. That kind of takes us into coverage. So dental coverage for kids, this is the good news. This is all the other bad stuff I said. This is the good news. Dental coverage for kids is almost universally available. A lot of kids have it available through their parents' plans through their employers. The EPSDT, Early Periodic Screening and Diagnostic and Treatment program in Medicaid and CHIP ensures that dental services are available for kids. It's required as a part of that EPSDT program. So that means in our state, 300,000 kids on Medicaid and CHIP have access to dental care. It's great. It's also maybe a little bit less well known that the Affordable Care Act, the ACA, includes dental coverage for kids as part of the 10 essential health benefits that must be offered in plans. So between those 3 areas of insurance, it's almost all kids are eligible to have dental insurance. A couple of other things just to note that are feathers in our cap. Fluoride varnish, which is just kind of painting fluoride on the teeth, is covered in cane care for both medical and dental professionals. That's cool because not every state does include that for medical professionals. So in Kansas, you can take your kid to a well child visit. The pediatrician can put on fluoride varnish. There's several times you can do it a year, and it's perfectly safe. So that's great that kids can get that coverage. The Head Start programs, federal, state, local level, individual building level, they have a huge emphasis on oral health care and education. In most Head Starts, kids are brushing their teeth during the school day. This is a big part of what they do, and they also learn about it. And then again, I just wanted to note the Bureau of Oral Health does provide that school screening and school sealant program, so there's some other resources there. Here's just a little bit more then about dental coverage. So in 2020, we were able to partner with the Kansas Health Institute on a study of dental insurance in the state. I think everybody probably knows that every year the Kansas Health Institute puts out I think they call it the Kansas Insurance Report. Shows us what percentage of Kansans have have insurance, what don't, where are some of the needs. I've been asking myself for years, why don't we know that about dental insurance? They've been asking that too, so we were able to partner with them on looking at some existing data to determine what percentage of Kansans have access to dental insurance. So this is really cool. This first fact here, 80% of kids have dental insurance. That totally jives with what I said about most kids have access to dental insurance. In Kansas, that's true. So that's another really good thing. But here's the slightly worse news. About twice as many Black and Hispanic kids lack dental insurance as white kids. So that's something that needs to be worked on significantly. I think we end here with some solutions for kids, and then we'll go into adults. So there's a handful of things that are in progress that I'm very excited about that you as legislators have been championing. First of all, in 2019 and 2020, the legislature approved dental rate increases in Medicaid. That was the first time in about 20 years. I think we all know the dental rates in Kansas are, well, anywhere. The Medicaid rates are just not great, but the legislature has really invested over the last few years in rates for dental care. That's an important step towards improving the provider network, so thank you. That's a big step, and that's something important. A couple of other great things in progress. Right now in the FY 2022 supplemental and then the 2023 Senate budget recommendations, there's an extra $250,000 for school-based oral health services, and that is the school screening and school sealant program at KDHE. So that's, investing in that improves their capacity. They can do even more of that great work. And also, and I'm super excited about this, the FY 2023 House and Senate, both versions of the budget at this point include recommendations to extend Medicaid dental coverage to adults. So the reason I'm talking about adults, talking about kids, is the research all says that if adults can have access to dental care, they're much more likely to take their kids. Families go together. They prioritize it as a family if they all have access. Ongoing needs are things that we're working on that I just kind of put out here for you to think about as well. The numbers I've shown you clearly show that we need to do more outreach for both private and public health insurance programs to encourage kids to have preventive dental visits. It's happening more in private insurance than it is in public, but there's a lot of work that can be done. I mentioned earlier making age 1 dental visits the best practice. There's so much work that needs to be done to have dental providers and families understand, hey, you can take your kid at age 1. You can take your kid if he's 9 months old and has a tooth. You take your kid. This next one, including dental care and the foster care requirements, I'm saying that with a little bit of hesitation. I think it's something to think about. I know the foster care system is just unbelievably complicated and burdened. We've had some conversations in one of our local oral health coalitions with foster parents who say, look, we're not even focusing on dental. We're not told to. We don't think about it, but we know that's a need. So I think that's just something that could be considered as we think about the foster care system. Are there ways to include dental as one of the priorities? Providing education for dental providers about meeting the needs of kids with disabilities. Like I said, some dental providers are just not comfortable, so that the comfort needs to be raised. And of course, the social value of accepting Medicaid. There's so many kids that can be and do so much more if they're healthy. The next one I didn't talk about yet, but creating incentives for hospital-based dental care for kids with disabilities. Some kids with disabilities can't tolerate being in a dental office for various reasons, and the only place they can even get a cleaning or an exam or a filling or anything is in a hospital under sedation. It's sad. I wish that wasn't the case, but that's just the case for a lot of kids. It's also extremely difficult to get that care. We get calls at least weekly, sometimes more often, from families saying, can you please help me find somebody who can do sedation dentistry? There's just a very small handful of places to do that around the state. So we do see other states working on incentive packages around that, and that might be something else to take a look at. And then lastly, we got the CanCare re-procurement process hopefully coming up here soon. Thinking about dental as a part of the whole package of what is offered to Kansans, as opposed to an add-on, would be one of our recommendations. So now I'll kind of go through the same sort of information, but with older adults. I think I can do it faster even, so we can get on to some discussion, because I know you got a lot on your minds. The first is back to our report card. There's only 2 measures on our report card related to older adults. I've highlighted those here. They're both about tooth loss. About a little less than a third of older adults have lost 6 or more teeth due to dental decay. That's important because once people get to the point where they have 20 or less teeth, that's when it starts to really impact their nutrition and their overall health. So the more we can keep adults with all their teeth, the healthier they're going to be, the longer. And then about 14% of older adults have lost all of their natural teeth. You can see we got C's on those, and you can look at the actual report card, and there's more data in the report card, but we can obviously do a lot better there too. Back to the Kansas Department of Health and Environment. This is another survey that the Bureau of Oral Health has done. Back in 2018 and 2019, they did a survey of nursing home residents. It's really similar to that school screening program where they go out to schools. In this case, they go out to nursing homes, screen older adults to see what their status is. So they did it in 2018-19, and then they did it again in 2021. I'm showing you data and not necessarily being able to interpret all of it, because some of it I have some questions myself. just about what does this tell us? The one piece that I think tells me something is, if you look at the last item there, in 21% of people with untreated decay in 2018 and 2019, and that went up, more than doubled, to 45% in 2021. I have to think that's partly due to the pandemic, because it was so hard to access dental care for a little while there. So I have to think that's part of it. But just know that, I mean, even at 21%, it's kind of like the kids. When you got that many people in nursing homes with untreated decay, you've got some big problems. The last thing there that doesn't have a statistic beside it is the survey also showed almost half of residents who had teeth, it says had substantial oral debris. That means they had stuff in their teeth. That means they had food kind of accumulating in their teeth. What it means is they're not getting their teeth brushed, and they're not getting flossed. They're not doing any of that in the nursing facilities. I'm not indicting nursing facilities, but over half, or about half the residents clearly aren't having that done. So that's something that's an area of concern, because that means this untreated decay is just going to go up. And I'll go back to the Surgeon General's report and a few facts there. The fact is, very few older adults these days do lose all their teeth. So many improvements have been made over the years. There's disease prevention, there's disease treatment, there's water fluoridation. There's so many things that have really improved people's teeth over the years. I did that little infographic there is actually from the American Dental Association, and that's from an actual study of Kansans. 84% of low-end Kansans say, I accept that I'm going to lose teeth as I age. I don't accept that. They accept that. I think that's something we can do something about. 84%. I mean, that feels like, you know, my grandparents' generation sort of expectation, and we're in 2021. I feel like we can do a lot better. Dental implants are another thing here. They're a really safe and effective way to replace lost teeth. They preserve bone structure, but they're super expensive, and they're out of reach for many older adults. And then, you know, lastly, older adults here are living longer than before. That means they're living with more chronic diseases and more health conditions that are managed well when they can be managed by medical and dental professionals. So again, that medical dental integration. Just a couple, I think a little bit more about facts here. Older adults are just generally at higher risk for poor oral health than younger adults because they, by and large, I'll talk about this in a minute, lack dental insurance. They have, as I said, underlying health conditions, lack convenient access to care. This is a really critical one. People who live in underserved urban areas, who live in rural areas, who live in long-term care facilities, they really lack convenient access to dental care. They also, of course, have limited financial resources. Once people are retired, they often have limited incomes, fixed incomes. Another point here, people who are hospitalized are much more likely to get pneumonia if they have a dental infection. It's a correlation there. I'm not a dentist, so I can't give you the science of that, but it's a strong correlation, and we know that older folks do end up in the hospital, and pneumonia is common. So basically, you know, controlling dental disease helps keep people healthier longer and helps them manage their other conditions. Moving on to dental coverage. So I was super excited to tell you kids have access to dental coverage. Older adults do not have access to dental coverage. It's the exact opposite story. Medicare doesn't cover dental. People pay into Medicare their whole lives working, and they get to 65, start to enroll in Medicare, and they say they don't realize it. It doesn't cover dental. Medicare supplemental plans do include dental coverage, but they're really unaffordable for a lot of Kansans, a lot of people. So that's a factor. I've got some data about that in a second. And then Medicaid coverage for dental for older adults, or any adults, is not consistent from state to state. As I said, with any luck, Kansas will be there here soon, but many states don't include dental coverage for adults. Let me get into the charts here. This is again from that Kansas Health Institute study. About half of older adults in Kansas don't have dental insurance coverage. So half. I mean the facts line up directly with what we know about the insurance coverage available. But here's where it gets interesting, I think. About a quarter of older adults do have dental coverage from a plan like Medicare Advantage, so we know about a quarter of people can afford that, and I think that's great. About 20% of older adults still have dental coverage through an employer somehow, so that's also great, but that means pretty much everybody else is uninsured. And at this point, I have lost my page. There it is. Okay. So on to solutions. Again, in progress, the great news is the House and Senate Budget Committee recommendations at this point still include funding to extend Medicaid dental benefits to cover to adults. That will impact older adults living in the community, living in long-term facilities, anything like that. Ongoing needs to implement a dental benefit in Medicare, and that's nothing you can do about here, but I just want to highlight for you because I think that's important. Last year, Congress got the closest it's ever been in the history of history to getting dental benefits added to Medicare. It was very close. We all know how the legislative process works. The issue wasn't the issue that didn't get passed, not because people didn't believe in it, but because other things took precedent. So that's still on the table. Including dental care and daily toothbrushing in home and community-based services and institutional plans of care is something we really would love to be able to dig in and work on. And this is a little bit like what I mentioned about foster care. When people are screened to be eligible for HCBS services or for institutional services, they get plans of care that outline their activities of daily living and how much assistance do they need with bathing, dressing, toileting, eating, all the basic activities. Toothbrushing is not on that list. It's not a hard thing to do, but it's not on that list. So if we could just include something as simple as toothbrushing on that activities of daily living in the plans of care, that would be tremendous. And some of these others are what we saw under kids, providing education for dental providers about meeting the dental needs of older adults, adults with disabilities, and about the value of providing Medicaid dental coverage. Just like some dental providers are nervous about providing care to people with disabilities, it's also kind of intimidating to provide it for older people. That's also kind of scary for many. So that's something, it's an education issue. And then creating, again, incentives for hospital-based dental care, because that's also an issue for this population. I added on this one some data needs. I do have this dream that every year, and I think a handful of people at the Kansas Health Institute have this dream too, that every year when the Kansas insurance report comes out, it includes dental and medical insurance. So we have a clear picture on what health coverage do people have. And then the other, and I hadn't addressed this before, but the other one I wanted to bring up is emergency room usage for dental pain. The Medicaid program spends a lot of money on that. Private health insurance spends a lot of money on that. But people can't get any dental care in an emergency room. If you have no insurance and you have nothing else, but you've got this toothache, it's hurting so bad, where are you going to go? The emergency room. But all they can do is provide you with an antibiotic prescription, a pain medicine prescription, that's it. And your problem isn't solved. So, but we also know that emergency rooms, by no fault of their own, don't track the data consistently, so we don't have a really good sense of what the number of people is that's going to the emergency room. The last numbers I saw from the Kansas Hospital Association are around 19,000 a year emergency room visits with dental pain. That's a low number because there's not all the hospital systems report into that. So, okay. I think that's all I have to say. That's a lot of stuff. I appreciate your time. I'm happy to dig into any of these things. Happy to do some research if you have questions that I didn't get to. So thanks.
Thank you. I kept thinking of questions and then you would answer them. So, yeah, there was a lot there. I knew there would be. Do we have questions? Representative Smith.
Thank you, Madam Chair. Fluoride treatment. You say you can get that how many times a year?
Oh, goodness. I may have to look that up. I feel like I remember the insurance regulations allow kids to get it like 6 times a year, like 3 on the medical side, 3 on the dental side. I can look that up to be certain I'm right, but it's 6 is not wrong. It might be more.
I supposedly, with the state, had a good medical plan, and they didn't pay for the fluoride treatment. You had to pay that on your own. So, 6 times would be great. But like I say, when you pay it on your own, it's pretty expensive. So,
and that's actually an interesting point because it's for kids. Adults can get it too, and it's generally not covered for adults.
Yeah.
So that's something that's worth talking about. Absolutely.
Thank you.
Yeah, thank you.
Thank you, Madam Chair.
I've gotten them. Representative Helmer.
Thank you, Madam Chair. One of the slides, and you can correct me if I'm quoting it wrong, it made reference to mental health causing some type of the cavity. And so could you expound on that?
I can tell you what I know, and I can do more research. What we know is that a lot of times the medications people take when they have behavioral health issues can cause dry mouth, which cause dental problems. So dry mouth is a part of that. That's my only answer right now. I can do some more research and find out. This is where I know enough, but I'm not a dental professional, so I'm going to stop and consult with a dental professional and get back.
That helps a lot. I was
Okay.
wondering if it was something along those lines or if that it was being attributed to that they were so incapacitated they couldn't take care of their own teeth. So that helps me a lot. Thank you very much. Thank you, Madam Chair.
That's certainly one issue. Another is a lot of times folks, people with behavioral health issues tend to smoke more than others. It's a soothing issue. Smoking is terrible for your teeth, obviously. So there's lots of issues, but yeah, thanks. Thanks for that question.
I want to point out that Representative Johnson brought props today.
Bravo.
I've got Representative Vaughn next.
Thank you, Madam Chair. On your solution slide, you talked about incorporating oral healthcare into the home and community-based services model. Could you talk about what that might look like?
Yes, I can start, and then I think it's something that I think we and others ought to be having conversations about. What I'm picturing is, years and years ago, I worked in the developmental disability system, so I'm kind of relying on some old history. I remember that there's a screening tool that is used, and there's lots of questions that are asked about how independent are you when you need to get dressed, and how independent are you to eat, and all these things. There are no screening questions about how independent are you with brushing your teeth, like maybe washing your hair, but not brushing your teeth. So first of all, just including a screening question to ask how independently you can do those things. But the second one would be then making it a standard part of the plan of care, and there's a kind of a script of the things that need to be covered in the plan of care, making that be one of the things. We know that on your survey, on your screening, you said you needed assistance, so that means you need X hours per week of assistance with that. So you would get time on your plan of care for doing that. Does that help?
Yeah, that seems like a fairly simple addition that would make a big difference. So thank you. Thank you, Madam Chair.
I've got Representative Smith. Did you have another question? Then we're going to go on to WebEx, and Representative Neighbor has a question. But okay, well,
Real quick.
go ahead.
I just heard one time, smoking is a horrible habit. And if a person smokes, they're really not taking care of their body, so they really don't take care of their teeth either because they don't care. So more of a comment than a question. So
I can't disagree.
thank you.
Okay, Representative Neighbor, did you have a question?
Yes, thank you, Madam Chair. I worked in dentistry for 11 years, and there was a question by Representative Helmer regarding mental illness and teeth cavities and things. Really, anybody that takes a medication that causes dry mouth, whether you have a mental condition or not, can cause decay. And you have a higher propensity for decay if you are taking certain kinds of medication. So when you have a prescription given to you, it's always wise to check the side effects so that you are aware of that and you can keep up with your dental appointments. In fact, I did sedation dentistry too. So for about 9 years. So anyway, that's just an answer to Representative Helmer's. And adults can get, if your insurance covers it, on adults you can get fluoride twice a year, but only if it's covered. And as our speaker has stated, Medicare doesn't really cover much except one exam, an x-ray, and a cleaning. But what happens with that is if you have perio disease or any kind of gum issues, it is not going to fully cover a periodontal maintenance or periodontal cleaning. It only does everything above the gum line. So maybe that makes some sense. Thank you, Madam Chair.
Representative Hoy.
Thank you, Madam Chair. On the KDHE's Bureau of Oral Health, the school screening program and sealant program, are there other programs that are going into schools? I know that at my son's school, they have dentists come in. Would there be other programs other than KDHE? And are these programs, patient visits, counted in the numbers that we're looking at toward the beginning of the presentation of children that have accessed dental care?
That's a great question. The answer is totally, it depends. It depends on, there are mobile programs that go out to schools. It depends on the school, whether they want that. It depends on the providers, whether they can get there. It depends on that symbiosis. And then it depends on whether those programs affiliate with the Bureau of Oral Health and then share that data. They have to be calibrated to make sure they're capturing data, looking at problems and agreeing with the same results. So as long as they are affiliated with the state, then they might be, but there might be a little bit more going on than is said. Mm-hmm. Probably not a lot, but a little. Mm-hmm.
Tanya, where are we at statewide with fluoride, fluoridation?
We are at about 65% of Kansans have access to optimally fluoridated water. It goes up and down a smidge, but it hovers around 65 all the time. Mm-hmm.
Are there any communities that, I mean, this is something we worked together a lot about 10 years ago. Are there any communities where that's a hot topic anymore, or?
I'm knocking on wood saying no. No, I don't think so. The city of Wichita is one of the top 3 or 4 largest cities in the country that's not fluoridated. So that's why we're going to hover at 65% for the foreseeable future until that changes. I haven't, again, knocking on wood, I haven't heard about any communities talking about it one way or the other for quite some time.
Yeah, I haven't either. Do you still have, are you guys still sponsoring the oral champions?
Well, we have 2 dental champions in the room. Representative Helmer also is a dental champion. So so Oral Health Kansas has a program called Dental Champions Leadership Program. We actually don't have an active class right now, quite frankly, because of funding. We don't have the funding to do it. But it's a program that invites people from all walks of lives to spend the better part of a year together studying leadership from the Kansas Leadership Institute, studying Leadership Center, studying advocacy, coming up here, kind of getting to know what advocacy looks like, becoming legislators eventually, and then studying an issue and trying to decide what, looking at all aspects of an issue. What do we need to understand scientifically, socially, everything about it, and what can we do about that issue? So we actually had 2 classes specifically about community water fluoridation. Representative Helmer was in one of those classes. We don't have a current class right now, though.
Which class were you? You remember. So I was 7. Okay. Well, if that ever pops up, if anybody is ever interested in that, it was a great experience.
Yeah, class 7, class 8.
Yeah, 7? Was it you? Representative Wagoner.
Thank you, Madam Chairman. A very interesting presentation. It led to a lot of questions on my part. You folks, you're a private organization. You're not, and so who actually funds this? I mean, is this, where does your money come from?
That's a great question. Private foundations. So it's we're almost entirely grant funded. We have funding this year from, for example, the Health Forward Foundation in Kansas City is funding us to do a handful of things. We've got funding from a national health foundation called the CareQuest Institute. We've got a project we're working on with the American Heart Association around access to water bottle filling stations in schools. Those are our big ones. We've got several other smaller funders, but it's private health foundations. Mm-hmm.
We can continue. I'm really curious, your presentation, a lot of interesting facts, but you have a very strong emphasis on dental insurance. I mean, I've literally never had dental insurance till I signed up with, so I became a legislator. I mean, it was always such a low, what does it cover versus what it costs is kind of marginal. And so I'm a little shocked that, why would that make a difference? Isn't the whole thing with personal dental care? I mean, if dental insurance, let me just use a sort of basic number. If it's, $300, $400 a year, $30, $40 a month, but then it covers, like 1 or 2 cleanings and I mean, it's basically kind of a flip of the coin. You can just pay it out of pocket, or you can pay it through your dental insurance. I mean, barring having, some, like whatever, some more serious dental deal. But just for the regular person, what difference does it make? I mean, seriously.
No, that's a fantastic question, and I think I wish now I would have brought the entire Kansas Health Institute study so I could remind myself of working age adults, what percentage have insurance. I don't remember it off the top of my head. It's definitely not the whole working age population. The reason we talk about it is mostly because we focus on low-income folks who can't even afford that, $30 a month, and definitely can't afford out of pocket if they don't have any coverage at all. So that's the main reason we focus on it as a big issue. I actually had that aha moment yesterday too, kind of looking through that Surgeon General's report. They had some conclusions about, therefore, here's some policy things to look at. And I was a little surprised myself that almost all of them say, we need to look at coverage. We need to look at coverage.
Okay.
Yeah.
Well, let me ask a second question. I'm also very curious, particularly, I mean, on one of your charts, you do break down kids as far as free and reduced lunch versus not. And I'm just wondering, as far as just income level, how much of this is really more income level based and not dental insurance access? I mean, are there, like socioeconomic, like the numbers would be much different, or what? I mean,
Absolutely, yeah.
Do they break down that data ever that way? It
mostly gets broken down with Medicaid being kind of the dividing line, because kids universally are eligible for Medicaid and CHIP if they're low income enough. So it mostly breaks down around that as the socioeconomic divider. So that's why that report card, for example, lists things out between kids on Medicaid and kids not on Medicaid. Kids not on Medicaid doesn't necessarily mean they have private health insurance. They might be private pay.
Sure.
Yeah.
Okay, one more question. So, but it would be truthful that, I mean, if you can get 80% of the kids brushing their teeth every day or whatever, I mean, their parents encourage them to do that or whatever, versus a group that only 20% brush their teeth every day, you're going to have much better results, dental-wise. I mean, is there anything you guys work with that is changing people's, attitudes and somehow, I don't know, I mean, you see a lot of sort of brush your teeth every day commercials, I think. I mean, I kind of remember seeing those. But as far as what actually moves the needle on people's actual behavior versus somehow thinking that somehow dental insurance is some magic bullet.
Yes. So what I didn't talk about is some of our other work, which is around education. And we do a lot of educational programming for Head Starts, for long-term care, for people with developmental disabilities, around how do you make those habits and why do you need to make these habits. People with developmental disabilities, we even have a program specifically targeted at people with IDD to help people understand, if you're going to drink a soda, but then, rinse your mouth out, or drink a soda while you're eating, because that way you're having all the acid in your mouth at once, and then just drink water all afternoon. So we have a lot of educational programs we do around that exact issue. And I think I lost the thread of part of your question after that. I apologize. Oh, right. It's kind of just doing it over and over again. One of the things I talked about in terms of kids, and this is not what you asked, but kids, going to the dentist when they're 1. If you start making habits really early, you're just always going to have that habit. So I think it comes back to a lot of the socioeconomic status issue. Folks growing up and living in poverty, this may not be, brushing your teeth every day may not be the biggest priority. Making sure the heat's on may be the biggest priority. Parents, we hear stories a lot of the time about families who share a toothbrush. And those of us, this is why I kind of started out by saying we kind of think of dental care as cosmetic, because those of us who grew up with, with parents who had the resources to have toothbrushes for everybody, and who we went to the dentist every 6 months, and we had a cavity once in a while, but we took care of it. I mean, it feels like, why are we talking about this? But it's because there's such a huge swath of the population that didn't grow up like that and doesn't have those resources. Does that help? That helps? Yeah, I could spend another hour just talking about the educational programming too, because we do a lot of that, and because I think you're exactly right. This is what I wanted to say. We kind of think about access to dental care as a three-legged stool, or access to oral health as a three-legged stool. One is access to a provider. You have to have somewhere to go. One is access to a way to pay for it. So is that Medicaid? Is that private insurance? Is that out of pocket? And third is, I've never come up with a good word for this, but it's that the behavior issue that you're getting at, or the public health piece. You know, do you understand how and why? And do you have the skills? Do you have a toothbrush? Do you understand how to do that? Is that a priority in your life? That is the absolute third part, and we agree completely. That part's hard to legislate. That part is behaviors.
So that cavities and gum disease are infections and they are transmissible? How's that? I mean, you can siblings can give each other cavities? I mean, like, seriously?
If people drink out of the same cups, and again, I might have to rely on Representative Neighbor to fill in the blanks on the science piece, or one of my colleagues, but one of my colleagues, we have a dental hygienist on staff, and she teaches new moms, if the binky falls on the floor, don't pick it up, lick it off, and put it in the baby's mouth. Rinse it off, because if you have a cavity or ever had a cavity, you now put that in that baby's mouth. So sharing drinks, sharing that kind of stuff. I hadn't ever heard of that until I started this work either. This is kind of why I like to share that level of information, because lay people like us don't know that. It's surprising. Yeah.
Representative Neighbor and then we'll go. Representative Neighbor already had her hand up earlier, so.
If you can correct me.
Thank you, Madam Chair. There were a couple of questions that I can tack on and help you with. First of all, periodontal disease affects your entire body. If you're a diabetic, it enhances that. If you have heart disease, it enhances that. When I say enhances, it affects and can cause a lot more damage. That's because it's in the gums, and everything we do, we swallow. I mean, we chew, we swallow, and it's the whole body. Insurance for dentistry is not changed in over about 30 years. You can get coverage at $700, $900, $1,000, $1,200, $1,500, $1,700, and $2,000. So if you have a child who has bad teeth and they have to have, and the tooth is so rotted that they have to pull it out, what happens is you have a space there. And so you have to put in what's called a spacer, or that tooth won't have room when it comes in as a permanent tooth. So those run about $295 to $300 just for the spacer. The tooth extraction is going to be somewhere about $150 up to $300, depending on if it's a simple extraction or much more than that. So right there, you can see you've got $500 or $600 on one baby tooth. You have issues about where the mouth is too small. There's not enough room for the teeth. So then you put in a palate expander. Why do you do that? So that the palate can expand to allow for teeth to come in, and hopefully you won't have quite as much orthodontia work that you have to do. But periodontal disease in both children and adults, especially as they get older, can be transmitted through a kiss. Husband and wife can transmit it between themselves. And like she said, you drop that binky on the floor. If you have periodontal disease, you've licked it off. You have just now infected your child. So there's a lot of things I don't think people understand about dentistry that we still have a long way to go in, but it is about your whole bodiness, not just your mouth. So I'll leave you with that. Hope that helps a little bit.
Okay, Representative Mosier.
Thank you, Madam Chair. Thank you for your presentation. Yeah. As an aide at a hospice house for almost 10 years, I can you had one of the slides that showed the decay process in people in long-term care and stuff, and it being relatively high. Hospice clients can say, I don't want to get my teeth brushed tonight. I don't want to do it. They have that right. And my mom and dad both went through long-term care facilities at their end-of-life experience, and they too said, you know, if they didn't feel like it that night. So that might lend a little bit to why those numbers are elevated. Just.
Thank you. I was probably breathing funny, so thank you. I do appreciate you saying that, and I think that makes an awful lot of sense, especially in a hospice setting. You should have the right to decide what you want to do. If you don't want to brush your teeth, that's fine. That's another good explanation for why could those numbers look like they do. Absolutely. There's so much detail in all these details, right?
Thank you.
Yeah,
Thank you, Madam Chair.
Further questions, comments? Okay, thank you so much for coming today and spelling it all out for us. And Representative Neighbor, thank you for helping out with
Yes,
a couple
thank
of questions. So, committee, this completes our work for this week, and we are not meeting on Monday. We've got a couple of bill hearings that we're going to have Tuesday, and then I think, what do we have Wednesday? Do we have another hearing? Bill hearings, and then we should be done. I think we'll be on the call of the chair on Thursday, just in case we have something that we need to wrap up. So with that, we're adjourned, and see you Tuesday.